outset, I'd like to thank Cadila Pharmaceuticals for choosing me as a person to speak on such an auspicious day. And that too, after all of you have seen the video presentation from a man like Indravardhan Modi. He is a source of inspiration to many other people, many other learned people. So on this occasion, when they have chosen me to speak, I feel so honored that it gives me the privilege to talk something which he was very close to his heart. It was one of the innovations in which he had worked and had delivered and placed our country among the top slots, and where even the Western looks up onto us for various data. Usually they say that he is a man who grows old not by virtue of age, but by virtue of his vision and experience. Such a sort of man was Mr. Modi, and I salute and wish to learn a lot from his vision. And all of us will definitely with him, if not in person, but in mind and heart, to carry on his noble vision even after he is no more. Polycap has been introduced in this country from the past 1 year, and most of you know about Polycap contents. What I would really like to do is that, as Dr. Bhubaneshwar said, that cardiovascular diseases is a growing burden and one of the major killer of all diseases, and account for nearly 30% of global deaths, which is attributed to cardiovascular diseases. So that's nothing new. All of you know that. So what I would like to know is that we have a responsibility both as a state and as a physician. We have our own responsibilities to see how we are going to reduce this incidence of cardiovascular disease. And this is exactly where the status of Polycap stands. What I will do is that in this next few slides is try to really give you insight of the preventive aspects of your cardiovascular disease, so that you know at the end of the talk you really know where you have to place this fantastic molecule of Polycap. So it will be easier, and over the process you will know the exact fate and exact positioning of Polycap. So as all of you know, this is one of the major killer disease. It was just one of the surveys which was done by Harvard School of Public Health, and it was listed as one of the major cause of global deaths, and it represents roughly over 30% of all global deaths in the year 2010. And of the major cardiovascular diseases, coronary artery disease contribute the maximum, and most of the people have cardiovascular diseases. Amongst them, 69% have primary events and 31% have secondary events. So there is a huge burden of not only the primary events but also the secondary events which we need to look at. So CVD is the #1 cause of mortality all through the world, cutting across races and ethnics. So what about the scenario in the Indian setup? So the Indian epidemiological data is not very different from the rest of the world. Majority have the major cause of deaths is because of cardiovascular disease, ischemic heart disease rather, and even hemorrhagic strokes also contribute to the majority of the death due to various diseases. The first concept of Polycap came through this study, the intra-heart study, This was more of a association which was seen that the mitral infarction risk increases as the number of risk factors, as most of you know that there are various risk factors which I will be talking to you later on. As the number of risk factors increase, the chance of getting mitral infarction increases. So MI risk increases by 26 times when a person has all the 9 risk factors. That is both modifiable and non-modifiable risk factors. If a person has 1 or 2, maybe the risk of chances of developing cardiovascular disease is much lesser than a person who has got all the 9 risk factors. So, risk factors are very vital. We need to identify risk factors, and we need to identify the number of risk factors a person has, so that your interventions for that person could be very tailor-made, could be very targeted. So this is the same thing which has been even endorsed in the Lancet, which said exponential rise in MI risk with added risk factors. As the number of risk factors add, your chances of developing mitral infarctions increase. So what is our duty basically? Our duty is, as a physician, as a doctor, that we need to think a lot about the preventive aspects. So what are the approaches available for us? All of you have been reading SPM, you know the basic preventive aspect of any disease is you have a primary prevention. By definition, primary prevention is a prevention of the onset of symptomatic disease in patients without prior symptoms of the disease. He has no symptoms of the disease, but we want to prevent him developing symptoms of the disease. At this point, I am not talking anything of the risk factors. I am just talking about how you have to prevent a disease in a patient who is asymptomatic. So whenever you have your interventions based in this particular subset of population, it is taken as a primary prevention. Then we have the aspect of secondary prevention. By definition, this means prevention of death or recurrence of a disease in patients who are already symptomatic. He is already symptomatic. So now we need to prevent death in such person, and we need to see that he doesn't develop recurrent attacks of the disease. We have learned basically in SPM the primary and secondary and tertiary prevention of opportunities. Another aspect which is called primordial prevention, which most of us may not have listened, which calls prevention of development of risk factors causative of the disease. So this is where basically we're trying to target. We're trying to target the risk factors. And obviously the way you can reduce the chance of developing risk factors is obviously through lifestyle modification. So a healthy lifestyle modifications will act as a primordial prevention. But what we are going to look here, look into the particular slide, is basically a primary and secondary prevention. As all of you know, so when I have been talking about risk factors, you know that there are various types of risk factors. You have the non-modifiable risk factors, means which cannot be modified at no cost, and they are just like age, sex. For example, if you are a male sex, you tend to have more chances of developing cardiovascular problems. A particular race, like the black race, has got more chances. So this you cannot change. And if you have a family history of prior or premature cardiovascular events, then that also puts you at risk of developing cardiovascular. So these basically are non-modifiable. You cannot do anything. The second set of risk factors, what you normally have, is the behavioral risk factors. Like they come about your behavioral changes, that is sedentary lifestyle, your diet, your alcohol, your smoking history. Those are all behavioral risk factors. These two in turn will give rise to some amount of psycho or physiological risk factors. So ultimately a patient has to develop something. So he develops obesity, he develops hypertension, he develops various lipid abnormalities, and he may develop either a pre-diabetic or diabetes mellitus. So these are the physiological risk factors. So there is a interplay between these three types of risk factors, which ultimately gives rise to various disease process, various events. So what are the basic events and endpoints which ultimately will, these risk factors will culminate in? They are hypertensive heart disease, you have hemorrhagic strokes, your coronary artery disease, you have atherothrombotic strokes, your peripheral vascular disease, and last but not the least, sudden cardiac deaths. So these are basic endpoints of an interplay of these three risk factors, and this is what we need to prevent for such patients. We don't want our patients to have a hypertensive heart disease. We don't want he should have a hemorrhagic stroke. So that is where preventive treatment, preventive approaches come into play. So when I talk of primary prevention or prevention of patient who's asymptomatic, it can be in two ways basically. Either you make a population-wide approach that in a particular community you give a particular approach, we give instruction so that the entire cross-section of the community changes a particular habit, takes some particular treatment so that he modifies the risk factors. But that's a huge task if you have a population-wide approach. Alternatively, what you can do is that amongst these people, you can identify people who have high risk and make your appropriate preventive measures for such high risk patients. That's called as a high risk approach. I'm sorry, the slide is, sorry for the slide. What I would like to show you here. Suppose that this is a bell-shaped curve. Suppose you are going to assess serum cholesterol levels for a wide section of the population. You will find the majority of your patients will be in the doom of this one. The entire majority of the patients will have, suppose you take this FX as a patient having cholesterol of 200 milligram per deciliter. So anything above that, majority will be there. So you say that anybody who has got 200 milligram per deciliter, he needs to be treated. What we do, we don't normally, as you know, most of the people who have cardiovascular events tend to have a very moderate amount of risk factors in them. So whoever has got a cardiovascular event, if you are going to evaluate, most of them don't have all the 9 risk factors or all the 4 risk factors. You find most of them have only 1 or 2. The high risk factors are the people who are at the tip of this. Most ideal would be if you are going to have a population-wide prevention for such patients. Suppose a patient is having cholesterol of 200, you estimate for everybody and then give them statins or whatever it is, and then you try to prevent the disease. But in our setup, we are going to look not at the population but walk-in patients to our clinics. If you are going to have the population-wide prevention, the most daunting task of such thing is that there is a huge surveillance, you need a huge database, you need public health education, you need community organizations and partnerships, and you need policies, you need legislations. So it's not possible to have a policy-wide approach. So we have found the easy way out that we take the high-risk approach. So this is where even in such high-risk approach patients, you can really target your follicles. So whenever you're doing a high-risk approach, you need to do certain things. You have to make an individual risk assessment of the patient. You have to it's not just enough that making an assessment, you have to even match the risk with the intensity of the intervention. A patient who's got 5 risk factors, he may require a different intervention than a patient who has got 2 risk factors. So it's not just one thing which suits all. So you have to even grade your interventions. And last but not the least, you have to also have a calculation of the global risk score. in most of the patients, especially if they are above the age of 40. So this also becomes difficult for us in our day-to-day practice. Whatever maximum we do is that we make various parameters, biochemical parameters or assessments. So you need to even see the weight, the abdominal curve, and so many other factors. So can we really do something in which we don't need to see such risk factors and do something? Yes, maybe at this point you can also think, if you find one or two identified risk factors, maybe you can even use the polycap in these patients. So the primary prevention is what we are doing, basically high-risk primary prevention. And this is some of the basic ABCs of primary prevention which I wanted that most of you should know. That's why I put it here. That is A for aspirin, E for blood cholesterol, what we have to get it under control. If it's a smoker, C for cigarettes, we have to prevent. D for diabetes, get it under control. Exercise, then you have the food and diet modifications. G is for girth, so you need to see the central obesity by your waist circumference. And if it has got blood pressure, then that has to be brought to targets. And if it has got a pulse irregular, if a patient has got arterial fibrillation. At this point, I want to make a brief thing that initially what used to happen, you have a clinical cutoffs, you have a preventive cutoffs. But gradually, even now, previously, when a normal blood pressure was taken 140/90, maybe in a large scale, at some point even the targets have come down. So gradually there's convergence of these two values. So it's become easier. Suppose you have to treat somebody at 140/90 and then you have to think of prevention for somebody at 120/80. If the gap is much, maybe there will be some amount of inertia. If I'm going to get down these values and form a convergence of both these two things, maybe at some point prevention and treatment come together. So that's going to be very easy for us. As I told you, that age is one of the big risk factors, and IST is more than doubles after the age of 55, and you have seen most of it, men and women, is equal. As the age increases, the chances of getting ischemic heart disease will definitely double. And age is a non-modifiable risk factor, I told you already. This is one of the studies which is called as a prospective urban-rural epidemiological study, which was done, intercontinental study. It's called the PURE study. And the study aimed to assess the prevalence, awareness and control of hypertension worldwide, and with a simple thing as measuring of blood pressure. It was done in 5 continents, 17 countries. There were 528 urban and rural communities which were involved, and the total study population was to the tune of 1,53,000. It's a huge number, and they used one simple parameter, as hypertension, to see how that's going to vary among various subsets, various continents. This was basically published in the American Heart Journal. The PURE study, which showed that for certain people consuming 4 key proven medications. And what is the difference between the urban and population, and what is the difference between the income groups? So you find that, people in the higher income group were more able to take all the 4 medications. Maybe that their level of education was higher, maybe they were affordable. That's why the compliance part was much better than what it was in the lower income group. So normally you find that patients, you prescribe about 4 drugs and maybe the patient takes about 2 and drops another 2. So compliance is a very big factor, and most of the drugs are very essential. But still you find a lot of people, in spite of having a disease, don't take medications. And this is no different in the rural population also. It's the same. Somewhere there is a point in which the patients are not able to take all the 4 medications. What could it be? It could be that maybe the complexity of the treatment, or maybe the number, or maybe the age, maybe the economics. So how to address this problem? Obviously, they could want that we're going to put everything into a polypill and give it to him. Maybe at some point he's going to know. It is seen that most of the urban population have elevated levels of risk factors, and in the inter-heart study, it seems that 99% of controls had at least one cardiovascular risk factors. 90% individuals in the UK over 50 had elevation of cholesterol, blood pressure, and had at least one traditional risk factor for CVD. And CVD has been seen can be prevented if you are able to manage it very well. If you are able to look into the compliance of these medications. There is no dearth of therapeutic options. We have a lot of drugs coming in. So we have like antihypertensive drugs, we have cholesterol lowering drugs, we have antiplatelets, we have oral hypoglycemic agents, anti-obesity agents. Unfortunately, the anti-obesity segment is very bad now. We have no positive interventions for each and every risk factors we have. But in spite of having all the interventions, the number of cases, number of people suffering from cardiovascular diseases, both primary events and secondary events, are very high. It's on the rise. So what's the reason? So there is some missing link. We can do that, really reduce the risk by having individual interventions. Maybe treat everything to targets. Like we are talking of an LDL cholesterol, we say give a statin, and for a patient whose LDL cholesterol is more than 100, if you are achieving an LDL of more 30 to 38% drop, is good enough for him to prevent these cardiovascular events. And for patients who have got LDL of 100 and less, maybe you need to get your LDL cholesterol to 50 to 70. So the targets we know, we have the options. So we have to really put it in use. Maybe most of us putting it in use. Still, in spite of this, there is a wide gap. This is a table which shows the risk reduction as to the individual intervention. If you're talking about blood pressure control, your risk reduction is to the tune of 20 to 25%. If it is dyslipidemia, again, you're treating it 20 to 25%. And you're using an antiplatelet, you reduce the risk of cardiovascular coronary heart disease by 30 to 35%. So, in spite of that, you have a high patients who come with various strokes and cardiovascular disease. So, treating these factors alone individually is not just enough. So, risk reduction with combination therapies is not producing the results, desired effects. So maybe a better risk reduction is possible by combinations. This is one of the things which have been published in European Heart Journal. If you have anybody whose blood pressure reduced by 10% reduction in blood pressure and a 10% reduction in total cholesterol, it is not just an additive effect, but it's more than additive effect. We find a 45% reduction in cardiovascular disease. So combining drugs, two drugs, gives you such a big benefit. So some of the physicians felt that maybe at some point we can even achieve a cardiovascular risk reduction to the tune of 70 to 80%. When two drugs can give you a reduction of 45%, maybe that's a possibility. And that is where the concept polypill first took up. And one of the pioneers in the polypill, Dr. Salim Yusuf, he also had postulated, this is just a postulations, that if you are reducing, you are adding aspirin, relative risk reduction 25%, if you are using beta blockers, it's again 25%, if you are using liquid lowering agents of statins 30%, if you you're using an AC inhibitors, 25%, and a combined effect gives you a staggering 75% reduction in your risk factors. So it's 75 to 80% reduction in risk factor is possible. This is how where the basic work started. One of the earliest persons, the most interesting editorials that come out by Ward and Law, it is the most talked of person. He said that if you're going to have a combined effect, you can achieve 88% reduction in your risk factors. Let me tell you, this is not a control and an RCT or anything like that. This is basically a mathematical calculations which he had projected, and basing on this we had various Indian studies on polymers. So he is the first one to postulate. So as you know, that individual drugs have various effects. I have told you before also, and here in the last you can see if you are combining aspirin with AC inhibitors and the statin, there is a risk reduction, and odds ratio also is reduced quite significantly than using the individual drugs alone. As I was telling you, the problem to all such things is of compliance. And as I was telling you, patient continues or discontinues to use most of the medications, and it is seen that nearly 30% of the patients will discontinue one or more tablets which you prescribe by the first month itself. So what is that really we are achieving? The moment the patient leaves your clinic, within a month he is back to square A. It would have been better if he was taking all 4 medications, and his risk reductions could be much better. And these are the reasons why patients don't adhere to therapies. Treatment complexities, number of daily pills are so high, and sometimes he has got a lot of chronic conditions, so he felt fed up of using so many medications, and a certain hypertension, cost, and maybe they feel that some of them are still unnecessary. So when a patient sees so many medications, you feel that most of them are unnecessary. And pill burden is one of the major causes for non-compliance of the therapy advised by the physicians. And whenever there is a non-compliance, you find here in the dotted line, when the medications, if he is taking only one or no medications, his survival reduces. And now the question of a poly pill, that's a Polycap. We are not going to really look into the various compounds which have been used. Ideally, that you need to use a statin, you need to use 2 or more antihypertensive drugs, definitely out of which one should be a beta blocker and 1 AC inhibitors, and antiplatelet. So these are the basic composition of Polycap. Most of you must be now aware that Polycap had a long history. It was in the year 2003 to 4 that literatures were reviewed and new product development works first started. 2004, the protocol for clinical trials were made. It was a staggering 9-arm protocol trial. And 2006 and 8, the TIPS-1 clinical trial was completed. 2009, the international patent was filed. And 2009 treatment study result was published in the Lancet. And 2010, Polycap was launched in the Indian market in a big way. And 2011, the TIPS-2 also clinical trials were completed. And 2012, it was the Welcome Trust Award was presented, and the TIPS-3 clinical trial was commenced. And this trial is still ongoing. It's been done in more than 1,000 patients in 2 countries. So we have really hardcore evidences. And these evidences are basically on secondary prevention, let me tell you. Primary prevention polypill trials are never there. Even the benefit of aspirin individually in a primary prevention is still doubtful. Maybe the only compound which ever gave some benefit is the statin. In the AC inhibitors and others have not shown any benefits in the primary prevention aspect. So whatever we are talking now is basically about secondary prevention. So it's a hard gelatin capsule which contains 3 antihypertensive medications. It contains your diuretic hydrochlorothiazide in a dose of 12.5, etolone in the dose of 50, ramipril is given in the dose of 5 mg, and 1 lipid-lowering drug, that is simvastatin, basing on your 4S trial. That's why they've used that, and also because the costs were much lesser, and 1 antiplatelets were given. And most of you can refer to your textbooks the role of antiplatelets and your statins and your AC inhibitors in secondary prevention is very clearly given in a very nice tabulated form. So where can we benefit from Polycap? As I was telling you, Polycap in a primary prevention, you can use it in a high-risk patient, able to really assist the patients, and you can use it in pre-existing disease such as heart disease, stroke, peripheral vascular or peripheral artery disease, diabetes mellitus. Those without pre-existing disease, if it is in the older age, because more than 95% of deaths from IST or strokes occur in people who are more than 55 years. As I told you in the previous slides, the risk of MI increase doubles when in a patient with more than 55 years, and hence a large number of patients can benefit through this Polycap. So Polycap doesn't mean just picking up something over the counter and putting it into one hard gelatinous capsule and then give it to you. When you're giving a capsule, you have to see whether the individual components which are there in the Polycap act the same way when they're given individually. Is there any change in pharmacokinetics? Were there any drug-drug interactions within the capsules? So that has to be assessed. No, then every Tom, Dick, Harry can put all the components into one capsule and give it to you. That is where innovation comes. That is where you find the vision of Mr. Indravardhan. That's where it comes. It's not just giving you something which is authentic, giving something which is innovative, and giving you something which is affordable. Here you can see that every drug which has been used, you'll find that most of the efficacies remain the same. They don't change. Be given individually or the compound being within the Polycap. The bioavailability and the effects are the same. They don't alter. So this has been studied. So the first trial which was made for Polycaps called the TIPS-1 clinical trial. The Indian is called the Indian Polycap study trial. It was a design of 9 arms. It was a randomized, double-blind comparative trial. It was multi-centric, over 50 centers in India, and it included about 2,053 individuals without cardiovascular disease. So maybe at some point, some of the patients have primary preventive aspect also. They were basically between the age of 45 to 80 years, at least one severe risk factors. They were put on active treatment for 12 weeks and then given a follow-up of 16 weeks, and endpoints were measured in terms of BP, heart rate, lipids, urine convaxin D2 levels, and even their safety and tolerability of the medications were also assessed. And the chief principal investigator was Dr. Salim Yusuf. So these are some of the arms of the TIPS 1 trial, you have a plain aspirin arm, you have a simvastatin arm, you have thiazide arm, you have a thiazide with ramipril arm, you have a thiazide with ethanol arm, you have a ramipril with ethanol arm, you have all the three antihypertensives one arm, and you have a antihypertensive with aspirin minus statin arm, and you have an arm for Polycap. So each and every aspect was taken care that you get the proper insight into the aspects of the Polycap. And the Polycap, you have roughly about 412 patients. As I told you, some of them had no evidence of cardiovascular disease. And you had, besides that, you had a lot of people who were women patients, and you had a lot of, even a large number of diabetic patients. These are the various 9 arms. So if you look at the mean changes in blood pressure, both systolic and diastolic, if you are using 3 BP lowering agents separately, you have a systolic and diastolic blood pressure reduction to the tune of 7 to 5, and very similar in the Polycap. So here again it proves that the Polycap, the pills placed on the Polycap does not alter. The effects are the same, efficacy is the same. And you find that even the efficacy of ethanol remains the same. You find a heart rate reduces both in the Polycap and ethanol. This again regarding simvastatin and the Polycap comparison, they are the same. There was similar reduction in total cholesterol. Antiplatelet efficacy also were the same, using aspirin alone or in the Polycap. And regarding safety comparisons, they were the same. Use the drug individually or in combination. This was again the Polycap TIPS 2 trial in which they have taken more low dose to high dose. That means they have used 2 capsules of Polycap. And they have done the same thing, and they have also assessed. And here also the results were very good. You can see the using the low dose Polycap to the high dose Polycap, cardiovascular benefits are the same. They are not much altered. But you find a marginally better reduction in the incidence of strokes, which have been observed using a double dose of Polycap. That basically, as we found the J-curve effect, maybe if you're going to reduce your blood pressure, the reduction in hemorrhagic strokes are much lesser than the cardiovascular benefit. So it does definitely have a place in therapy. 4 out of 5 deaths from cardiovascular occurs in developing countries, and there are millions of patients, especially in India. There are roughly 45 millions of patients in similar conditions, and a lot of lives can be saved if you're using this particular molecule. So now you know exactly that what we're talking of Polycap is primary prevention, high risk, at least in those cases. Secondary prevention in patients who have got multiple risk factors. Compliance is very good. Bioavailability of the drug in the Polycap is unquestionable. Cost, what I came to know from the companies, is absolutely good. I think it should be about 14-15 rupees per capsule. So what is that? We have everything in one capsule. It's only that we need to put it in use. We need to have our personal experience of using such molecules. The little word of caution is that maybe in patients who are little blood pressure a little on the lower side, maybe those patients are a little careful. Even though the blood pressure drop is not very significant in the trial which has been shown. So Polycap is a late stage near to market opportunity. It's already in market, and it's a boon for the developing countries. It has been showing the efficacy and safety in large trials also. The market trend shows an increased use and acceptance of the combination drug in various cardiovascular preventions. It's very encouraging communications with the US FDA on the regulatory pathway of Polycap, and is very soon going to be approved. And maybe, as Mr. Modi thought and he has visualized that the knowledge should now go from the east to the west. Maybe this is the torch bearer of this, and with this I again salute the great visionary, and we hope that we learn a lot from him. Thank you.
Thank you, Dr. Kishore. Now the session is open for question and answers. Or any comment from the floor?
Thank you, Dr. Kishore, for your nice talk. I want to comment on 2 points. One is the public health aspects of this non-communicable disease, NCD. Definitely it's a challenge for the entire world, and almost every nation has taken measures how to control it, and India is also a signatory to it. And as you know, Odisha, in our state also 6 districts are now covered under this NCD program, where detection, treatment for hypertension, diabetes, stroke and cancer are going on. So definitely, because now NCD, the mortality due to NCD has superseded that of due to communicable diseases. Almost non-communicable disease mortality is almost 55 to 60% now. But one thing, so far as the Polycap concept, Polycap concept is not new, it's almost 1 decade old. It has got many admirers as well as critics throughout the world. The one challenge for this Polycap concept is the fixed dose combination, because there is very little flexibility, and you must have now come out this week itself, after the ATP4 guidelines has come out, where there is no target for this cholesterol, and almost as you have already, because this Polycap concept is for secondary prevention mainly, for secondary prevention what they have told, it is the statins is the number 1, and the statins what we are giving now, it has completely changed in the ATP4 guidelines. Now we have to see the intensity of statin administration. So intensity, they have come out with low intensity, intermediate intensity and high intensity. So the statin dose is very high. Now if you go to secondary prevention, the statin dose is, because the atorvastatin and rosuvastatin, these are the 2 statins they have taken, and rosuvastatin almost 10 to 20 milligram and atorvastatin 20 to 40 milligram. So if you go by that, then I think I now suggest there should be some modification in this Polycap package. So they should come with some flexibility, maybe with 20 milligram also, maybe with 40 milligram also, so that wherever we require, we can give with 20 milligram, we can give with 40 milligram, we can give with 10 milligram, so like that. So there should be some modification of the Polycap which can be mostly better accepted in the professional sector. Thank you.
Dr. Pandegiri, you are right in the sense maybe we need modifications, that's what I was saying. In fact, I was discussing, especially regarding, a lot of controversy was there regarding ethanol, and we have large number of trials with metoprolol, which we have been used to the test of time. Now the drug prices have been reduced. Maybe at some point metoprolol should be also thought of. Even the newer vasodilator beta blockers can be thought of. Regarding your aspect of dose of statin, there's no levels fixed. Exactly, that's what I told. Whatever be the level of statins you use, be 20 or 10, If you are able to achieve a LDL reduction of 30 to 38%, that's good enough, because that's going to give you a reduction in your atherothrombotic processes. So lower levels also not, there's no cutoff. So the degree of drop in LDL is very important. We in the Indian setup, maybe the 80p3 guidelines are okay, 80p4, but at some point we tend to use lower doses of statins. We have been using post-MIN and immediately we use 40 to 80 milligrams of atorvastatin. We as physicians, post-event or post-interventions, we are a little bit skeptical of using even 20. So maybe the higher doses, at some point you will get multiple combinations of polypills. You will have maybe with rosustatins. Simvastatin, again now the incidence of new onset diabetes mellitus more with simvastatin, others. Maybe the newer statins would also be introduced. And I was talking to the company people, and they said they're even working on replacing the ACE inhibitors, because the patients who don't tolerate ACE inhibitors, maybe the ARBs also will come out into the concept of polypil. So this is just a beginning. Maybe at some point we'll have many new molecules, many more trials before not just simply putting in different doses of different molecules. Maybe we need to have a lot of studies and before these molecules can really come into the market. But definitely I think they would be looking up. That's what I had talked to these people, Dr.
I would like to add something. As per the pure study, all countries of the world were categorized into 3 categories. So India was the least economically developed country. Least. And second thing, 80% people were without drugs in India. So when we are thinking of polypil, we should not think of the best. What will be best? What will be affordable? What will be effective? And what will be very much suitable for this country, where 80% people do not take medicine or stop taking medicine when the economical condition is very poor. In that light, I think polypil is a boon to Indian context. We should not think of the best thing, what will be affordable, what will reduce the pill burden, and what will be effective.
If you see the large number of patients in our country, the total number of patients, because 30% of patients in India, and this is the absolute number of patients, is a huge. As Professor Dr. Bhubaneshwar said, the large number of patients are missing the doses. So I had a very small project going on in our hospital that adherence to drug therapy or non-adherence. In my finding, for about 3 months, to project my daughter, I had the opportunity to be associated with my daughter. She was working in IAMICON. So, our finding for the period within 3 months, we made a study about, say, 700 or 800 patients. So, non-compliance, non-adherence rate was very, very high. So, taking to that picture, this polypil concept for the present time, I think it will be very much useful. Those variations will be there. That will be required in individual therapy, individual patient approach. But so far in group or secondary prevention is concerned in our country setup, this polypil concept will be highly useful. Thank you.
Actually, the basic concerns for polypil is that once you give a polypil, maybe there are little apprehensions about patient not adhering to the lifestyle modifications. So that's one aspect.
One incident forward. This morning we had a stroke of senior personnel in our college. So one of our patients, so before starting the course, so I had suggested that I record the blood pressure, and after also the event is completed, I record the blood pressure. So while I visited one patient who had blood pressure and diabetes, and he has minor stroke also. He was taking 7 to 8 medicine. He was taking last 4 or 5 years. He is not my patient actually, he is going somewhere at SCD. So he just told Peg brother, sorry, if medicine also 8 or not a medicine, I am getting difficulty and I am forgetting many times. Kichi nahi in combination, you go take whole day requirement surgery. You just go and talk to a doctor, the doctor is treating you, and there is some solution. We can be helped. This is today morning's incident.